Welcome to the Deep Dive. Today we're exploring a really profound shift happening right before our eyes. This transformation of biology into pure data, especially in medicine. And, if there's one area that's been a demanding proving ground for this future, it's lung cancer. It kind of begs the question, what happens when machines don't just process images, but truly learn to see radiology with, well, surprising fluency? So this deep dive is your direct route to understanding the cutting-edge intersection of AI and cancer care, specifically within lung cancer. We're going to unpack a truly landmark meta-analysis synthesizing a staggering 315 studies. Yes, you heard that right. Hundreds of individual research efforts all pulled together.
Yeah, and our mission here really is to distill the most vital nuggets of knowledge from this huge body of work. This isn't about AI as some distant theoretical promise. We're showing you how AI in oncology is already delivering actionable, measurable results. It's fundamentally reshaping how we diagnose, stage, and plan care for real patients. We're moving past those promising headlines to, solid aggregated evidence.
Okay, so when we talk about cancer care, what's often the most challenging aspect for clinicians? I mean, is it purely technical or is there something maybe deeper?
It's the uncertainty. That's the big one. Just think about the daily dilemmas. Is this suspicious nodule truly malignant? How aggressive is it actually going to be? Which specific therapy will benefit this particular patient the most? These are the really high-stakes questions that weigh on every single decision.
And that's precisely where this meta-analysis steps in, I imagine, to tackle that uncertainty.
Precisely, yeah. This study doesn't just look at one model in, say, one hospital. It pools data from hundreds of imaging studies for lung cancer. It gives us this panoramic view of diagnostic accuracy and, crucially, survival risk stratification. And it's this scale, really, that fundamentally shifts the conversation from, well, maybe it's promising, to something demonstrably actionable. It gives us a much clearer path forward.
You mentioned how this meta-analysis tackles uncertainty. A big part of that, I guess, comes from the sheer volume and quality of the data, especially imaging data. How has that become such a game changer compared to the traditional methods?
Well, traditionally, pathology has been our gold standard, right? You get a tissue sample, look at it under a microscope, but, tissue is scarce, biopsies are invasive procedures, and tumors, crucially, are dynamic. They evolve over time. So a biopsy is really just a snapshot.
Right. And imaging offers something fundamentally different, a broader view.
Exactly. Unlike a tiny biopsy snippet, imaging captures the whole lesion and the surrounding tissue all in a single session. This is absolutely vital for getting a complete holistic picture of what's going on, something a small tissue sample often just can't provide.
Okay, and that complete picture is where AI steps in, transforming those images into what we're calling radiomics. How do machines actually, extract meaningful insights or measure at scale from what we just see as pixels on a screen?
Yeah, it's pretty clever. Think of it like breaking down a picture of, say, a tree. Not just seeing the overall color, green, but measuring its texture. Is the bark smooth or rough? Its geometry, how many branches, what are their angles, its intensity, how bright or dark are certain areas. Radiomics basically does that for a CT or MRI scan. It turns those individual pixels into literally thousands of these quantitative features. It's a sophisticated computational analysis that quantifies patterns, many of which were hidden before.
So these subtle numerical signatures within the image.
Yeah.
That's what the AI then learns from.
Precisely, yeah. Sophisticated AI models then connect these thousands of features directly to diagnosis or prognosis. It's not just some black box making guesses. It's advanced quantitative measurement at a scale we've never had before. It lets us extract far more information from an image than the human eye ever could, and importantly, do it consistently across large populations.
Okay, that makes sense. So with that understanding of how these machines... See, let's finally get to the payoff. What did this massive meta-analysis actually find? What are the cold, hard numbers for diagnostic accuracy?
The numbers are, they're quite impressive. For diagnosis based on imaging, we're looking at a pooled sensitivity of 0.86.
Okay.
A pooled specificity, also 0.86. And an area under the curve, or AUC, of 0.92.
Okay, let's break that down. For our listeners, what do those sensitivity and specificity figures 0.86 mean in a real clinical scenario, like day to day?
Right. So imagine you have 100 patients come in with suspicious lung nodules. With these pooled numbers, an AI using these models would correctly flag about 86 of the true cancers. But just as important, it would correctly reassure about 86 of the patients whose nodules aren't cancer. Tell them they don't have the disease based on the scan. Now, it's not perfect. No medical tool ever is. But it's profoundly useful clinically. Think of it as a consistent second reader. or a really effective triage tool, or even a way to standardize diagnostic thresholds across different readers.
And that AUC of 0.92, what does that really tell us about the model's overall power to distinguish between cancer and not cancer? How should we interpret that 0.92 number?
Yeah, an AUC of 0.92 is excellent. Basically means if you were to pick one patient with cancer and one patient without cancer at random, the model would correctly identify which is which about 92% of the time. It's a kind of holistic measure of how well the AI separates the sick from the healthy across all the possible diagnostic cutoffs. It really demonstrates very strong overall performance.
So it's not just about a simple yes-no for cancer, but can it tell us more granular details about the tumor itself? What did the study reveal about AI's ability to, say, distinguish different types of lung cancer?
That's where it gets really interesting, actually. The study highlights AI's strong performance in these more personalized tasks, too. Things like distinguishing invasive from pre-invasive disease,
Oh, okay.
classifying the major lung cancer subtypes, and even predicting specific molecular features like EGFR mutation status just from the imaging data alone.
Well,
That's a pretty sophisticated capability, right? Moving way beyond just simple detection.
okay. So it's good at diagnosis. What about prognosis?
Mhm.
Predicting how a patient might do long-term.
Yeah, what's truly fascinating here is how well this analysis holds up in prognosis. That's an area where, frankly, a lot of AI claims tend to get a bit softer. But for survival risk stratification, patients flagged as high risk by these AI models. They have more than double the hazard of death. The pooled hazard ratio was 2.53.
Ah.
And there's a similar significant boost, a 2.80 hazard ratio for the risk of the cancer progressing.
More than double the hazard of death. I mean, that's not just a statistical curiosity, is it? That sounds like a really profound clinical signal. What does that mean for an oncologist who's making treatment decisions?
It means AI in oncology isn't just good at finding cancer, it's also remarkably good at identifying which patients are really in trouble and likely need more aggressive intervention, or at least much closer monitoring. This kind of prognostic power allows oncologists to, well, more confidently push for closer follow-up, maybe expanded staging tests, or starting systemic therapy earlier when the data really screams it's necessary. And conversely, it gives more confidence when the data suggests a watch-and-wait approach is appropriate, hopefully avoiding unnecessary interventions for those lower-risk patients.
Right, that makes sense. So we've talked about these impressive outcomes, diagnosis, prognosis. Yeah. But let's pull back the curtain a bit. What's actually happening, under the hood? How are these machines able to see all this?
Well, the meta-analysis details two main ways AI sees. First is what we discussed earlier, radiomics. That involves segmenting the tumor, right? Isolating it. Then extracting hundreds, sometimes thousands, of these texture, shape, and intensity features. Classic machine learning models then learn patterns from these, let's call them handcrafted features, features we've predefined based on our understanding.
Yeah, handcrafted features. And the second approach, you mentioned deep learning.
Exactly. Deep learning, particularly using things called 3D convolutional neural networks, or CNNs, takes a different path. Instead of us telling the machine exactly what features to look for,
Right.
deep learning just ingests the raw images directly and learns its own features. It often discovers incredibly subtle, complex, non-linear patterns that no human could ever handcraft or probably even perceive. And the analysis shows these 3D CNNs have particularly strong diagnostic performance, which makes intuitive sense, right? Tumors are three-dimensional objects. A 3D model can process the tumor's entire volume, understanding its full shape, its extent, how it relates to surrounding tissues, much more like how a surgeon might visualize it before an operation.
So it's a bit of deeper, maybe more intuitive understanding of the tumor's physical characteristics just from the scan.
Precisely. And this goes far beyond just a simple yes cancer or no cancer answer. These radiomic signals, whether handcrafted or learned by deep learning, correlate strongly with the underlying histology, the microscopic structure of the tissue. And as you mentioned earlier, even with key molecular features like EGFR status, it's truly remarkable how much biological information is actually embedded in those pixels, waiting to be extracted.
If we connect that to the bigger picture then, predicting molecular features just from an image seems like a huge leap forward.
Yeah.
What are the real-world implications of being able to do that?
Oh, it's potentially transformative for workflows. It could allow for triaging molecular testing, deciding who needs it most urgently, maybe guiding biopsy sites to the most informative or aggressive part of the tumor, and potentially making first-pass therapy decisions much faster while waiting for the full molecular workup.
Okay.
Now, crucially, it doesn't replace the need for tissue biopsy, let's be clear on that, but it focuses attention, it saves valuable time, and it could significantly reduce the need for patients to undergo repeat invasive procedures. This is exactly the kind of practical leverage and efficiency gain that precision oncology should be aiming for.
Okay, so the potential is huge. But as impressive as these findings are, the meta-analysis also gives us a crucial reality check, right? It outlines some of the field's current habits. It mentions most studies are retrospective, many lack true external validation, there's high heterogeneity between studies, and publication bias likely exists. Given these, significant limitations, how confident should we really be in these pooled results? Are we maybe at risk of overstating AI's current capabilities?
That's an incredibly important question, and you're right, the authors of the meta-analysis are very clear on this point. While the pooled evidence is strong, these limitations definitely highlight the road ahead. The authors explicitly call for more prospective, multi-center trial studies designed from the start to test these models in diverse, real-world settings. And they call for stronger reporting standards across the board. This is, without a doubt, the roadmap to truly reliable AI in oncology. And it is absolutely achievable, but it requires clinical and technical teams to plan together right from day one, understanding these potential pitfalls.
So it sounds like while the promise is undeniable, there's still a rigorous path ahead to really embed this reliably in clinical practice. What does a sort of builder's checklist for real-world adoption actually look like based on what we've learned?
Okay, a builder's checklist. First, absolutely critical. Build for distribution shift. What does that mean? Well, imagine an AI trained only on scans from one shiny new MRI machine at a major academic center.
Right.
What happens when it sees images from an older, lower resolution scanner in a community hospital, or images interpreted by different radiologists with different habits? Performance can drop. So models must work robustly across different scanners, different hospitals, different patient populations, different radiologists. You almost have to expect performance to drop a bit when you take it outside the lab, and then design your workflow to absorb that drop gracefully.
Okay, anticipate the real world. That makes perfect sense.
Okay.
What's next on the checklist?
Second, it's really critical to prefer time-to-event modeling. Now, for those maybe less familiar with time-to-event modeling, what it means is instead of looking at simple binary outcomes like alive or dead at 12 months, which kind of hides the rich reality of survival data, methods like Cox proportional hazards allow us to model the timing of events like survival or cancer progression and how different factors proportionally influence that risk over any given period. It gives a much richer, more dynamic, clinically meaningful picture than just a single snapshot at one arbitrary time point.
Got it. A more nuanced, ongoing view of risk then, not just a yes-no at one point.
Exactly. And finally, a huge one. Treat interpretability as a requirement, not a feature. Clinicians don't need, a complex lecture on neural network architectures. They need a model that can, ideally, point to the specific region in the image that drove its decision and provide a clear probability or risk score they can actually use in their clinical decision-making process.
Yeah.
Nobody wants to prescribe a potentially life-altering treatment based on a black box that just says, "Trust me." Interpretability isn't some luxury add-on, it's an essential part of patient safety, and it's absolutely crucial for getting doctors to actually adopt and trust these tools.
Okay, that checklist makes a lot of sense. Build for the real world, model time properly, and make it understandable. So with these insights in mind, where is AI already making a difference today in oncology? Where are the practical gains?
We're definitely seeing immediate practical gains starting to emerge. Using AI, perhaps as a safety net in screening programs or for follow-up scans, helping catch things that might be missed. We're seeing it used to help fast-track high-risk patients identified on scans to tumor board discussions or for additional staging tests, and using those radiomics cues we talked about to help decide which nodules look most suspicious and should be biopsied first, or maybe when to just repeat imaging in a few months for a clearer answer.
Right.
For example, just imagine a 65-year-old patient, maybe a former smoker, with a newly diagnosed lung nodule. Traditionally, the approach might be watchful waiting, monitor it for months, but if an AI model flags that patient with that 2.53 hazard ratio of death we mentioned, well, that immediately shifts the clinical thinking, doesn't it? It changes from let's watch and wait to we need to act now, maybe ordering a PET scan much sooner, or starting discussions about targeted therapies earlier. It's really about empowering faster, more precise action based on risk.
So this really isn't about replacing the clinician at all, is it? It sounds more like extending their capabilities.
Precisely. Yeah, none of this replaces the clinician's judgment or empathy or experience. It extends their reach, it amplifies their diagnostic capabilities, and it makes those incredibly hard, high stakes decisions just a little less blind, a little more data informed. It provides practical gains that can scale across large patient populations, allowing doctors and nurses to focus their unique human expertise where it's truly most needed.
So it's important we keep our feet on the ground here. As you said, lung cancer is a very heterogeneous disease. And while AI performs remarkably well in subtype classification and even predicting things like EGFR status from imaging, molecular testing is still the definitive gold standard for selecting specific therapies, right? So
Yeah.
how do we ensure we keep AI in oncology grounded, given its, immense potential, but also the need for rigorous validation?
Yeah, this raises a really important point. How do we prevent overpromising and underdelivering? I think the answer lies in deploying AI where the evidence is genuinely strongest right now. We need to measure its impact meticulously in real clinical practice, not just in research settings, and then expand its use only as more robust, prospective data arrives confirming its benefit. Ultimately, patients win when the claims made about AI actually match the hard data and demonstrably improve clinical outcomes. It's all about rigorous, steady, evidence-based integration into care.
Exactly. So, for you, our listener, thinking about all this, here are maybe some distinct calls to action based on this deep dive. If you happen to be a clinician, perhaps you can ask for tools that start to bring these pooled gains, these kinds of diagnostic and prognostic insights, into your daily workflow in a usable way. If you're an engineer or a data scientist working in this space, your mission is clear. Build for that external validation, build for interpretability, and then design studies to prove that performance prospectively out in the wild. And if you're a hospital leader or administrator, maybe champion a pilot program, one that actually measures patient-centered outcomes like survival, quality of life, time to treatment, not just technical metrics like EUC. And then, crucially, openly publish those results, good or bad, so the whole medical community can learn.
Yeah, I think the overarching message here is pretty clear. The evidence base for AI in oncology, particularly lung imaging, is already robust. We're seeing high pooled accuracy in diagnosis and truly meaningful separation and survival risk stratification. The fastest path to real world impact is actually surprisingly simple. Identify one critical decision point in patient care that really matters. Integrate AI medical imaging thoughtfully into that decision process, and then make the outcome measurable. Track what happens. That is how AI in precision oncology moves from being on the cutting edge to becoming just standard care. And
Mhm.
ultimately, that's how more patients will see longer, better lives.
It really is an incredible transformation we've looked at today. Thinking about going from the raw, pixelated data of an image to extracting these actionable insights that can literally, as you said, double a patient's calculated risk profile or help guide a precise, potentially life-saving biopsy. It's truly astounding to witness this evolution in real time.
So, what does this all mean for you listening? As AI continues its relentless march, turning more and more of biology into analyzable data, how might this fundamentally shift our understanding of disease, even beyond lung cancer? What other, demanding, brutal teachers in medicine are just waiting for AI's surprising fluency to unlock their secrets? And maybe more critically, how might all this redefine the roles, the skills, responsibilities of doctors, nurses, all medical professionals in the coming decade? This deep dive, I think, shows us we are really just at the very, very beginning of that quite extraordinary journey.